Good afternoon, and thank you for being here. Today, I'll be presenting my Doctor of Nursing Practice project titled Improving Hospital Throughput at an Urban Academic Medical Center. First, I'd like to thank the DNP committee, especially my DNP chair, Dr. Teresa Gallicatos, for helping facilitate this project. So, a quick overview about me. I obtained my BSN from Queen's University of Charlotte. I currently work as a patient logistics nurse as well as a SANE nurse, and I will, of course, be obtaining my DNP from Maryville University. Now, ED overcrowding continues to be a significant challenge in healthcare, with over 131 million ED visits reported annually in the US alone. Boarding admitted patients in the ED, meaning that they remain in the ED due to a lack of available inpatient beds, can result in care delays, reduced patient safety, staff burnout, and operational inefficiencies. So, this isn't just an ED issue, it's a symptom of hospital wide throughput problems. And in response to these ongoing challenges, my project examined whether the internal efficiency ratio, or the IER, which standardizes the hospital's transfer open or closure status, could help manage hospital capacity without worsening ED boarding metrics. So, the purpose of this quality improvement project was to evaluate whether the IER could be used as a predictive tool to guide hospital transfer open or closure decisions without worsening ED boarding metrics. The primary aim was to assess whether the implementation of the IER had any impact on ED boarding time and the number of boarded patients. And a secondary aim was to generate predictive models that link hospital occupancy with ED boarding metrics. And the ultimate hope was to support more proactive, data informed decisions around patient flow, especially in a facility that routinely faces high volume, high complexity admissions from both internal and external sources. So essentially, we were trying to answer the question, does this tool work? And if so, does it help us better manage throughput without creating unintended consequences in the emergency department? So this is the actual IER calculation that's used to determine the facility's transfer open or closure status. And as you can see, it encompasses many of the input and output factors that play a role in a hospital's overall throughput. And based on the IER value, these are the thresholds that determine whether the hospital is either open to all transfers, closed to external transfers, but open to internal transfers, or closed to all transfers. And the DNP project that was formulated for this project was for ED patients with inpatient orders. How does the use of the IER to dictate intra-hospital transfer status compared to no use of the IER impact ED boarding times and ED boarder volume? This project was guided by the Translating Evidence into Practice, or TEP, framework, which was developed by Pranavas and colleagues. It's a 4-phase model that's designed to support large-scale quality improvement in healthcare settings by helping bridge the gap between evidence and real-world clinical practice. And so this TEP framework shaped every phase of the project. In phase 1, we synthesized the existing literature to support using predictive tools like the IER to manage hospital capacity. In phase 2, we identified a major local barrier, which was that our facility lacked a standardized method for determining when to open or close to transfers. And that's what led to the development and implementation of the IER. And the third phase helped us to identify performance metrics, which are ED boarding time and boarder volume, to evaluate whether this tool was actually making a difference. And finally, phase 4 emphasized staff engagement and education, consistent execution, and iterative evaluation. And this structure ensured that the intervention wasn't just a one-time change, but part of a larger shift towards data-driven hospital operations. So, in reviewing the literature, four key themes emerged: ED boarding and hospital overcrowding. ED boarding is consistently linked to increased morbidity, patient dissatisfaction, and resource strain. And studies like Lamb et al. And Franklin et al. Show that boarding is a hospital-wide issue and not just a ED-specific problem. Predictive tools and upstream interventions. So, research by Bartlett et al. And Burdett et al. Highlights the value of proactive predictive tools in hospital capacity management, aka tools that help make informed decisions before overcrowding happens. Hospital occupancy and throughput. Multiple studies confirm a direct relationship between inpatient occupancy and ED boarding. For example, Kellen et al. Found that once hospital occupancy exceeds 90%, operational inefficiencies spike and the patient movement slows across the board. And financial and operational impact. Evidence from Hammer et al. Shows that optimizing patient flow can yield significant financial benefits. And they found that a 1 hour decrease in ED length of stay can make room for thousands of additional patient visits annually and generate millions in additional revenue. So overall, the literature strongly supports the implementation of predictive system-level tools like the IER to proactively manage hospital throughput and reduce ED boarding. This quality improvement project employed a retrospective pre-post design to evaluate the impact of the IER on ED boarding metrics at a large urban academic medical center, or AMC. And the design was selected because it allowed for an observational comparison of outcomes before and after the implementation of the IER without requiring active patient participation. And the sample for this project consisted of 243 days of de-identified data extracted from electronic health records using the Epic Slicer Dicer tool, which enabled identification of population-level trends in ED boarding time, boarder volume, and hospital occupancy. And this included 120 days before and 123 days after the implementation of the IER. The inclusion criteria focused on adult patients admitted through the emergency department under acute care services, while the exclusions were applied to pediatric and obstetric cases to ensure data consistency. And this project was, of course, approved by the Maryville University IRB. And this methodology provided a structured evidence-based approach to evaluate whether the IER could serve as a predictive tool for improving hospital throughput and decision-making related to transfer status. And just as I mentioned on the previous slide, data was retrospectively collected over 243 days, 120 days before and 123 days after implementation. The data came from Epic Slicer Dicer tool, which allowed for the extraction of de-identified patient flow information like ED boarding time, boarder volume, and hospital occupancy rates. And to evaluate the effects of the IER on ED boarding metrics, both descriptive and inferential statistics were utilized. The descriptive statistics helped summarize central tendencies, variability, and distribution for each variable, aka ED boarding time, boarder volume, and hospital occupancy. And for inferential analysis, the independent samples t-test was initially selected to compare pre and post intervention means. However, a Shapiro-Wilk test was revealed that ED boarding time violated the assumption of normality, which prompted the use of the Mann-Whitney U-test for that variable. The ED boarder volume data were normally distributed, allowing for the use of the t-test for that outcome. And to explore the relationship between hospital occupancy and boarding metrics, Pearson correlation and simple linear regression analyses were conducted, and these results showed a moderate positive correlation between hospital occupancy and ED boarding time, with a correlation coefficient of R equals 0.528 and P less than 0.001. And regression modeling indicated that for each 1% increase in occupancy, ED boarding time increased by approximately 20.8 minutes, and boarder volume increased by 0.19 patients per day. So these predictive models were central in identifying key trends and planning for proactive capacity management. The results of the project showed that the implementation of the IER did not produce statistically significant changes in either ED boarding time or boarder volume, but this finding was actually favorable because it demonstrated that using the IER to guide transfer decisions did not exacerbate ED crowding, and that was even when the hospital was closed to internal or external transfers. And here you can see a box plot that shows that comparison of those pre and post intervention results of ED boarding times. And on this page, we have another box plot that gives the same visual of the pre and post intervention results, but for ED boarder volume. And just as I mentioned earlier, there was a moderate positive correlation between hospital occupancy and ED boarding time, indicating that as occupancy increased, so did ED boarding delays. The predictive regression models that were developed supported this relationship, and collectively, these results supported the conclusion that while the IER did not directly reduce boarding metrics, it provided a safe and reliable method for standardizing hospital transfer decisions without contributing to ED congestion. So again, the findings suggest that while the IER did not significantly change ED boarding time or volume, its implementation didn't lead to negative consequences. And this supports its continued use as a safe, structured approach to managing hospital transfer decisions. A notable outcome was the identification of hospital occupancy as a key contributor to ED boarding delays. A moderate positive correlation was found between occupancy and boarding time, reinforcing the value of predictive models to inform operational planning. So though the primary outcomes remained stable, the IER introduced consistency and transparency to transfer decision making, and this highlighted an opportunity to enhance the model by integrating real-time forecasting and building in flexibility for unique clinical scenarios. And like many quality improvement projects, this one faced a few limitations. First, the findings may not be generalizable to smaller community or rural hospitals, because the project was conducted in a large urban academic medical center with complex patient flow dynamics. And another limitation was that the IER did not directly address inpatient bed constraints, which is one of the major drivers of ED boarding. But the tool was designed to improve decision making, not to expand capacity, and ultimately this limited its overall impact on throughput. Additionally, the lack of a control group makes it difficult to isolate the IER's effect from other concurrent operational changes. And while the study design was appropriate for this setting, future research could benefit from a more controlled approach and broader implementation across diverse hospital environments. This project has several important implications across nursing practice, healthcare policy, and future research. From a practice standpoint, the IER offers a structured and data-informed tool for managing hospital capacity without compromising ED flow. It empowers clinical and operational leaders to make transparent, consistent transfer decisions that support safe patient placement. And for policy, this work highlights the need to develop standardized transfer exception criteria, especially at tertiary and quaternary care centers. These exceptions can ensure that timely access for patients who need highly specialized services, even when hospitals are closed to routine transfers. And from a quality and safety perspective, the predictive relationship between hospital occupancy and ED boarding metrics supports the integration of real-time capacity forecasting into hospital workflows. And this kind of anticipatory planning is essential for minimizing delays in care and protecting patient outcomes. So overall, the results point to future research opportunities, particularly in evaluating how tools like the IER can be adapted for smaller or research-limited settings, or even how additional variables like operating room demand can enhance predictive accuracy. This project provided several meaningful benefits to both the organization and the broader healthcare system. So first, it demonstrated that the IER could be used safely to manage transfer status without negatively impacting emergency department operations. And this is a critical insight for a high volume academic medical center. And it also introduced a standardized approach to transfer decision making, which improved transparency and communication across departments. And these predictive models developed through the project offered valuable tools for anticipatory capacity strain and guiding resource allocation. And perhaps one of the most impactful benefits was the foundation this work laid for continuous quality improvement. By using real-time data to inform hospital operations, the organization now has a framework that can evolve with the future system needs. So in conclusion, this project evaluated the IER as a predictive tool for guiding hospital transfer decisions. And although the IER did not significantly reduce ED boarding times or boarder volume, it also did not worsen them, which affirms that its operational safety and value in supporting sustainable throughput strategies. The project's predictive modeling revealed a clear correlation between occupancy and boarding, emphasizing the importance of anticipatory planning. And if given the opportunity to repeat this work, additional input variables such as OR add-ons and ICU holds would be integrated to enhance accuracy. The post-implementation development of transfer exception criteria was a direct result of the study's impact, reinforcing the value of balancing structure with clinical flexibility. And on a personal level, the DMP journey has deepened my ability to lead systems level change, transform evidence into practice, and engage in interprofessional collaboration. And this project was not just a scholarly exercise, it was a meaningful contribution to operational improvement and a reflection of how DNP prepared nurses can drive innovation across healthcare systems. So thank you all for your time and attention today. I'd like to now open the floor to any questions you may have. If you think of something later or would like to connect further, please feel free to reach out to me via my Maryville University email.